Hey, welcome and thank you for joining us. The Global Health Institute, in partnership with Muscat's Global Health Programs and the Global Health Alliance, is excited to welcome you to this academic year's last installment of our Global Health Speaker Series, showcasing the multidisciplinary aspects of global health work and research. It is my great pleasure to introduce Dr. Lesley Weaver, who will be presenting anthropological perspectives on global mental health in India. Dr. Weaver is an associate professor of global studies and director of the Global Health Program at the University of Oregon. Her research focuses broadly on the social production of health and illness. In India, her work explores how the day-to-day management of type 2 diabetes shapes North Indian women's abilities to participate in social roles considered appropriate for women of their age, class, and caste group. She also studies how South Indian women explain and understand distress and how and where they seek help for stress management. In Brazil, Dr. Weaver's work has examined how food insecurity influences physical and mental well-being. In addition to this fieldwork, she co-hosts and co-produces the American Anthropological Association sponsored podcast, Speaking of Race, linked in the chat, and which explores the history and present-day reverberations of scientific racism around the world. Welcome, Dr. Weaver. The floor is yours.
Thank you so much, Roxana, and thank you all for being here. I'll just go ahead and share my screen since I have some slides to share with you today. My talk today is about sort of anthropological, or you might say cultural perspectives on the field and the practice of global mental health. And as Roxana mentioned, I am a medical anthropologist by training. I have a background in human biology, and I've been working in India in particular for many, many years. And so the work I'm going to talk about today is based on a sort of long-term view of my career so far, studying health and illness and coping among women particularly. The talk itself is based around a paper that I recently co-published with some faculty at the University of Arizona. My collaborators, Dr. Krupp and Dr. Madhavanan, who are on faculty here, as well as some other collaborators from other institutions. That paper was titled, "Will Increasing Access to Mental Health Treatment Close India's Mental Health Gap?" And I'm referring you to this paper in case your interest is piqued by my talk today. It's based quite closely on this recent publication. So I want to start off just by addressing very quickly the question of what is global mental health. I know I'm not the first speaker in this series to talk about the field of global mental health, but I think it's important to make sure we're all on the same page. And I want to do that by giving you a very, very brief history of this subfield of global health and how it kind of came to be. So this is my very brief history. I start off this very brief history of the field of global mental health, which is actually quite new within the constellation of global health, with Emil Kraepelin. And although global mental health did not exist as a field when he was doing his work in the late 1800s, I like to think of him as kind of a progenitor of both modern day psychiatry and also the field of global mental health, which is very much predicated around psychiatric principles. In particular, Kraepelin was believed that the origin of psychiatric diseases was biological or maybe inherited or genetic, and he developed a textbook that described specific psychiatric diseases and their diagnostic symptoms, almost like a sort of precursor to the Diagnostic and Statistical Manual of Mental Disorders, or the ICD-10, which are the two sort of diagnostic manuals for psychiatry today. And so he was kind of an early visionary in that sense, and was very interested in what we would refer to basically as nosology, right? Understandings of what are psychiatric disorders and how do we know what they look like. His principles and the sort of clinical experience and outcomes of many, many experts since have been kind of enshrined or compiled into the manuals that you see here. And these have been critiqued by folks in my field, medical anthropology, in part because they are so seemingly objective, and yet we know that experiences of distress are so subjective and differ so intensely based upon people's personal backgrounds and sort of cultural underpinnings. And so particularly the DSM has been critiqued for presenting psychiatric disorders and their symptoms as being sort of culture-free and relegating most cultural variation in sort of psychiatric presentation to an appendix. That's changing with the recent updates to the DSM, thank goodness. But that's one of the sort of early foundational challenges, I would say, that's associated with working in mental health across cultures is this sort of tension between how universal can we consider, subjective experiences like symptoms of depression and anxiety to be, and how culturally particular might those things be. And that's kind of the space within which my entire talk is going to exist today. So getting back to our timeline, we have this sort of early emphasis in psychiatry and subsequently in global mental health on very specific sort of disease categories with clinical presentations that are recognizable, presumably, no matter who you are or where you live in the world. In the 1950s, the first psychotropic drugs were introduced, as was the first version of the Diagnostic and Statistical Manual that I mentioned to you a moment ago. And then another really important moment in the history of this field, this emergent field of global mental health, was the development in the 1990s of the disability adjusted life year, which many of you will probably know is a metric that was used to sort of develop the ability to compare the amount of morbidity and mortality caused by all kinds of disease, illness, injury, and disability states to get a sense of what was causing humans to get sick and stay sick and to die across the world. And so the development of this metric it's a combination between sort of years of life lost to illness, disability, or injury, and years of life lived with disability, injury, or illness. And that was an important moment because it was out of those global burden of disease studies in the late 1990s and the use of this new metric, the disability adjusted life year, to try to quantify how much disability and death people were experiencing based on all these different categories of health and illness. It was out of those studies that we began to realize that mental disorders have kind of a unique profile in the world of global health. Right, so this is an image showing you disability adjusted life years by sort of illness category. And you can see that there's a very large bump sort of in the middle here that's green, that's representing mental and behavioral disorders. And this image is showing you that that category of disorder causes more disability in people sort of considered to be in the prime of their working life, right, between the ages of 15 and 40 or so, than any other category of illness. And so it was these global burden of disease studies that really began to highlight how much mental disorders, particularly common ones like depression and anxiety, were impacting people during the sort of most otherwise active years of their lives. Now going back to our timeline one more time, as a result of those findings, the World Health Organization focused its World Health Report in 2001 on mental health specifically, and sort of put out this call to the global health community to pay more attention to what was going on with mental health. People listened, and practitioners began working in this field or continued working in this field. And then there was a series of sort of landmark publications in high-profile medical and mental health and global health journals in the early 2000s, really up until very close to the present, in places like The Lancet, PLOS Medicine, the World Health Organization got in on this, the World Bank got in on this, to develop this series of reports that were calls to action, basically, for a new field of study and also a sort of social movement devoted to addressing these large injustices and the sort of long ignoring of global mental health within the field of global health more broadly. And that's really how the field of global mental health came to be. And so a couple things that I want you to take away from this timeline are, number one, that it's very much grounded in the field of biomedical psychiatry, right? But predicated upon the idea that clinical disorders like depression and anxiety are recognizable entities that look the same no matter where you are in the world. Number two, that mental disorders are unique and important when we think about global human well-being because they are so often chronic and disabling, even though they are not as often the result of death as many other causes of disease, right? So they are important. And then number three, that there's been this real movement towards this recent kind of focus on thinking about global mental health as a big part of global health and a major priority. So out of that kind of early set of publications and this really quite recent interest in what's going on with mental health around the world have come heat maps like this one. So this is like most heat maps, it's showing you the greater the density of the thing at hand. In this case is the number of psychiatrists working in mental health per 100,000 people. So the greater the density, the darker the color, right? So the countries that appear darkest in this image are those that have a higher proportion of psychiatrists per 100,000 people. And folks who are invested in and who are publishing those kind of landmark pieces in global mental health in the early 2000s made the very obvious point that you can see here, that the vast majority of psychiatrists who are doing this kind of baseline mental health work exist in higher income Western countries. And we know, or we knew at that point, because of the global burden of disease studies, that there's lots and lots of suffering due to mental illness that happens all over the world. And there's many, many parts of the world where the sort of largest population densities in the world exist, say in South and East Asia. And we can see that there's very much less availability of psychiatric care in those settings, right? This came to be known as the mental health gap. And addressing the mental health gap became a major priority for the field of global mental health, right? So the mental health gap is the gap between the number of people who might need mental health care and the availability of that health care. So you might not see a very large mental health gap comparatively in a place like the United States or Canada, but you might see a very large mental health gap in places like, say, India, where I do most of my work. Early advocates for sort of greater attention to and investment in global health were looking at this. So they were talking about the mental health gap, and they also looked at funding available for mental health. So this is an image showing you the total development assistance that is devoted to each of these sort of categories of health and illness. And you can see that mental illness is up here at the top with only 0.4% of global health funding or global development funding devoted to it. And so people working in this field of global mental health, again, explain that the burden of mental disorders is so high, especially common mental disorders, but the funding is so low, right? So within this kind of broad picture of high need and low resources came an approach that is still very, very common in the field of global mental health called task shifting, or sometimes called task sharing. This is a workforce strategy that's been rolled out in lots of places around the world to try to address the mental health gap by shifting some of the sort of basic everyday mental health care tasks associated with providing mental health care to huge populations away from specialists. So getting away from this idea that, we need to have lots and lots more highly trained psychiatrists, and instead saying, well, many of the things that psychiatrists do, like screening people for mental disorders, basic case management, those could be done by people who have less specialized training. And that could be one way to quickly ramp up people's access to mental health care in places where there aren't a whole bunch of psychiatrists already trained and kind of waiting in the wings. So typically a task sharing approach, it's one that's highly endorsed by the World Health Organization, and it's been manualized. So this little image that's on the slide here is the actual task shifting, like how-to manual that the WHO produces. And the idea is to train non-specialist healthcare workers in those sort of basic functions of mental health care provision. Those people usually work under the supervision of a primary healthcare provider or perhaps a psychiatrist. And that way we can kind of democratize access to mental health care in a relatively efficient way. One of the early proponents of this approach is a scholar known as Vikram Patel. He's very well known, so I imagine some of you know him well. Well known for good reason. He is kind of been at the forefront of the global mental health movement and field since its development. And he was one of the first to pioneer a task shifting type of intervention in his home country of India. If you haven't seen his TED Talk, it's called Mental Health for All by Involving All. It's a great talk. I highly recommend it. And it's this study from the Lancet here that I have in the corner of this image that really put him, I would say, and this task shifting model on the map, so to speak. So this article is profiling a cluster randomized controlled trial that he and his colleagues conducted in India. The intervention that they mounted was a collaborative stepped care model involving community health workers to serve those sort of baseline case managers. They were even trained to, in this case, screen people for mental health concerns, but also deliver basic interpersonal talk therapy. Those folks worked under general practitioners, all of whom were overseen by a single visiting psychiatrist who oversaw the whole study. So this was a clinically based model of sort of testing this principle of task sharing to see if it could improve outcomes for people, in this case, who'd been diagnosed with common mental disorders. It was a very large study. There were 1,300 or 1,400 people in each arm of the study. All of them had screened positive for a common mental disorder. So in this study, that meant depression, anxiety, or substance use disorder. And one arm of the study got enhanced usual care, and one got this sort of unique layperson-led interpersonal psychotherapy and case management intervention. And so the study was designed to see if the addition of this particular type of sort of community-based healthcare worker-led intervention could improve outcomes for people with common mental disorders. And the primary outcome was the proportion of people who had recovered from symptoms of common mental disorders at 6 months. So as with most randomized controlled trials, unfortunately, the intervention window, the period of time is quite short. This is a results table from that particular paper. And when all these diagnoses are combined, so when they sort of lump all mental health disorders that they looked at into a single category, that's this group up here at the top. The intervention did show a modest effect with a risk ratio of 1.22, or signaling a 12.1% greater likelihood of having recovered at 6 months among those who received the treatment condition. So the collaborative stepped care model that I outlined for you a moment ago. But when they looked just at the subset of people with depression, which is the second part of the image down here, there wasn't evidence of an effect across either group. And granted, the sample size is much smaller here, right? So it's less than half of the total sample size. But this has always been a little concerning to me because depression is overwhelmingly the most common mental disorder that interventions of this type will be encountering and needing to deal with to address mental health gaps. And it does point to the fact that the overall effects of this intervention were quite modest, roughly on par with, other sort of intervention studies looking at talk therapy in general, right? And that's not to say that these results are bad at all, but they're not earth-shatteringly different than what we might expect from sort of typical mental health care. And so I've often thought, I'm not sure that these results are dramatic enough or exciting enough to me that this type of intervention should be considered the gold standard, or that it should be considered kind of like the main standard of therapeutic intervention in the field of global mental health. But in fact, it kind of has come to be that. So I know this is a long setup to what I'm going to tell you about today. So I'll just show you one last example of what this looks like in practice. So this is a very influential meta-analysis that was published in 2018, looking at a whole bunch of these sort of task shifting interventions and how they did, in fact, address the mental health gap in lower and middle income countries. They concluded that psychotherapies developed in Western countries can be implemented in non-Western countries when sufficient resources are available and without culturally adapting them. And that's been a little bit of a cause of concern for me as well, for reasons that I want to share with you now by sort of turning to my own and my colleagues' research on questions around sort of attitudes towards psychiatry and care-seeking practices among, in this case, women in South India. So this work is a collaboration with the Public Health Research Institute of India, an NGO based in Mysore, which is officially called Mysuru, located in South India, that was founded by two University of Arizona faculty, Purnima Madhavanan and Carl Krupp. And I'm very fortunate to be able to work with this group. The group has historically conducted a lot of research and intervention around women's reproductive health in the rural areas outside of Mysore. But starting in 2018, I began collaborating with the group to look at questions of mental health among women in the urban center of Mysore. Mysore is a mid-sized Indian city of about 1 million people. And it's a lovely place to go if you've never been there. I highly recommend visiting. So our guiding questions in this research were the following. Number one, what are the most common causes of distress for women in this setting? Number two, do women understand sort of biomedical models of mental illness? That is, are they familiar with concepts like depression and anxiety, and do they understand what those mean? Number three, are women aware of the psychiatric care resources that exist in their communities? So if they felt like they needed psychiatric care, would they know where to go? And number four, would women go, right? So if women felt that they were overwhelmed by distress and needed help, would they actually seek out psychiatric care? And these questions to me are really important because of my sort of slight concern about the idea that I think underlies a lot of the global mental health intervention work we're seeing, especially around task sharing and task shifting paradigms, that what we need to do is just make that healthcare more accessible, right? If we can make mental health care more accessible to people, they will use it, and that will close the mental health gap. That's kind of what these questions were designed to assess. Would that actually work in this setting? And as I mentioned, this is a collaboration that I began in 2018. It's an ongoing collaboration, and I also had many years prior to starting this collaborative work of work in North India with women who had diabetes and were dealing with mental health issues as well. So I'm going to draw sort of on my broader history of research in this field, but the main sample that's the focus of this talk today and of the paper that it's based on is this group of about 66 women with whom we spoke between 2018 and 2019. We conducted a series of individual interviews followed by focus group discussions the following year. And I think it's important to point out here that this is pre-COVID, right? And so I haven't done a whole lot of work yet on how the landscape of sort of women's sources of distress and well-being may have changed as a result of the pandemic, although I know that my collaborators have done some, so they can probably speak to that better than I can at the moment. But that's this sort of group from 2018 and 19 is going to be the focus of my discussions for the rest of today's talk. So for the individual interviews and to some extent for the focus group discussions, we used a series of sort of questionnaires asking women to tell us about their daily life routines, something stressful that had happened to them recently, the most common things that do give them stress over the course of a given day or week or year, with specific examples. And then we asked them quite a lot of questions about coping and help-seeking behaviors. So when they have those distressing experiences, what do they do and how do they manage it? We also did an assessment of sort of psychiatric literacy, which I've asterisked here because I'm going to tell you more about it. I think it's an important part of the studies to understand how we assess that, right? So we're trying to get a sense of, again, are women familiar with sort of psychiatric categories of disease and their treatments? And then we also, as part of these questionnaires, just routinely assessed women for, this should say depression, not depression and anxiety, a depression screener, the PHQ-9, a version of which had been validated and translated for use in Kannada, which is the language that the women in this study largely spoke and the language in which it was conducted. Getting to this asterisk here, we assessed psychiatric literacy by presenting women with 2 fictional vignettes that represented women demographically similar to them who were experiencing symptoms of clinical depression in the first case and clinical anxiety in the second case. So I've reproduced those vignettes here for you to get a sense of what they look like. So we read these vignettes to women, and then we asked them a bunch of follow-up questions. So things like, what would you call this experience that this woman is having, right? So in the first case, the protagonist feels sad and tired all the time. She used to go visit friends in her neighborhood, but she's lost interest. She sometimes feels so sad she can barely get out of bed in the morning. She's been having trouble sleeping and concentrating. Her appetite's gone down, right? Those are probably fairly common symptoms of depression that you might recognize. And then, excuse me, in the second case, the protagonist has been feeling worried and nervous about everyday things, laying awake at night, worrying. She's irritable during the day. She feels physical symptoms like her heart racing, becoming trembly and sweaty, lightheaded, stomach pains. So those are common symptoms of anxiety. And in both cases, these women self-identify as housewives, since the majority of women we worked with did as well. So we asked them, what would you call this? Have you ever had an experience like this? If you had this experience, where would you go? What do you think caused this experience? And other sort of similar questions to assess basically what would be women's own sort of culturally particular take on these 2 scenarios. So this is just a quick demographic snapshot of the study sample from those 2 years combined. Women were relatively middle-aged, 35 years old on average, and had on average 1 or 2 children and relatively small household sizes. They had quite a range of income and also quite a range of caste identities. And I think that's important because we did have some inclusion criteria in the study. So we wanted to speak with women who spoke Kannada as their first language or as their mother tongue or the language they speak at home, since we were partially interested in getting a sense of how people talk about, what kinds of terms they use to talk about distress. We wanted a relatively linguistically homogeneous sample. They needed to be women who were married. And initially, we focused on women who are Hindu, in part because Hinduism is by far the majority religion in India, but also because religion in this part of India often dictates what language is related to what language people speak at home, and also to sort of like practices and observances around things that would impact medical care seeking, like are women allowed to travel outside the home unaccompanied, etc. So within those inclusion criteria, this is otherwise a relatively diverse sample of folks across the socioeconomic and caste spectrum. And that's what these sort of middle indicators are telling you. And I just want to draw your attention also here to women's scores on the PHQ, which was the depression symptom screener. This is not a diagnostic tool by any means. And we did not select women for this study based on mental health status. So we were really surprised to find that a very large proportion of the study sample screened for some potentially clinically significant levels of depression. So 54% of the sample had some level of potentially clinically relevant depression symptoms. And then when we broke it down a little further, 27% of the sample had moderate or severe symptoms of depression. So I'm a little skeptical about that extremely high prevalence, although it does kind of mirror other studies that I've done in India. And there's only one population-based study I know of that was conducted in South India that looked at sort of population level prevalences of depression and anxiety. And this does map on. Regardless, there may be some inflation of numbers here. I think it's safe to say that this group of people is not strangers to distress. Many of them had experienced pretty severe distress, or were experiencing pretty severe ongoing distress. So I want to just move now to the results of this study and then wrap back around to this sort of question of global mental health and its approaches and what the implications of our findings might be for that approach in this particular study. And I'm going to do that by talking about those 4 sort of guiding research questions and what we found based on sort of looking through them. So the first one was, what is causing women distress in this setting? And after going through all these interviews and focus groups, conducting qualitative analysis, I was able to identify 7 kind of key themes that women touched on again and again as causes of distress. And here they are. So they were family conflicts, friend conflicts, illness, one's own or illness of close family members, various forms of insecurity or poverty, including financial insecurity, but others as well. Conflicts with neighbors was a really salient category for this group of folks. Balancing work and domestic responsibility, whether that work was paid, working outside the home, which was not true for the majority of women. Majority of women in this study were not working outside the home, or whether it was sort of keeping on top of domestic work. Women talked a lot about that. And then very few, but a few women talked about negative self-comparison as a cause of stress. So, looking at the sort of social station or lives of other people and comparing oneself and finding oneself lacking. And I'll walk you through a couple examples of the most common of these stressors. And I did list them in terms of going from most common to least common, right? So here's a quote from one woman in the study who said, "If my husband's scolding me without understanding me properly, I feel sad. I say, I'm with you all the time, but you won't understand me and my feelings. You just start shouting at me." So that's a sort of statement about marital discord, right? And another woman said, "People will speak nonsense about me and look at me meanly as though I had dumped something very bad. Perhaps I might have gone to a wedding, but people will turn it into something else." So here she's saying, people will see her leaving, like her neighbors will see her leaving her home, looking dressed up, and they'll accuse her of having an affair or sneaking off somewhere or doing something else that's illicit. She says, "I get tensed from all this and I don't feel relaxed to stay in this house." So this was a great and very common sort of experience women had of feeling surveilled and kind of judged by those around them. And what I want to draw your attention to here is that although there is variation in the kinds of causes of distress that women talked about, with the exception of a couple of these categories, most of the common causes and the ones women talked about the most were largely social or relational in nature, meaning they had to do with conflict in relationships. And that might seem obvious and unremarkable, but it's also instructive to think here about, I think, what is not present or what is absent. So women discussed very little feelings of sort of like existential angst or personal failure, struggles with self-esteem or rumination or these other sort of interiorly focused causes, with the exception of this negative self-comparison category that I mentioned to you here, but that was not a very common one. And this differs from what you might see in a group of people, say, in the United States, if you'd ask this same question. There tends to be, in my experience, having done this work for a long time, and in the experience of other folks too, there's often a profoundly sort of social and relational component to distress for women in this part of the world that is a little bit unique. In terms of the second guiding question of the research, do women sort of understand biomedical models of mental illness? This one was a little less straightforward. So women did occasionally use terms, clinical terms, like the Canada equivalents of depression or anxiety, but not terribly often. And we did not introduce those terms in the interviews because we didn't want to prime people to be thinking in that way. But they were able to distinguish, and they did frequently distinguish quite clearly between sort of mental illness or mental pain and physical illness or physical pain. The idiom that women use to describe body pain or generalized pain is maikainovu, which literally means like body hand pain. It's an idiom that refers to kind of generalized body hurting. And manasika novu, which literally means mental pain. So women did differentiate between these two. And I think that's important when we're asking questions like, do women sort of identify with biomedical models of illness, because if you think back to Kraepelin, he was very interested in figuring out like how to categorize mental illnesses in the same way that physical illnesses had been categorized. And that is that distinction between mental and physical illness, although we know that mental illness can affect physical health and vice versa, that sort of distinction between mind and body has been a key part of biomedical psychiatry since its founding. And so women did make that distinction, but as I mentioned a moment ago, they did not use a lot of clinical terms. So I often hear people in the United States say, I'm feeling really depressed today, or I think I might have depression. People pretty readily identify with those constructs that we've inherited from psychiatry in everyday talk in the United States. And I really have not seen that very much among the women with whom I work, either right now in Mysore or in my earlier work in North India. Instead, women often use women experience pathological distress in India, right? And that distress often has symptomatic overlap with symptoms of common mental disorders like depression and anxiety. But it doesn't necessarily mean that women are internalizing or sort of understanding their distress through the lens of depression or anxiety. And so a lot of the work that I've done in North India, and to some extent in South India too, looks at the terminology and the kinds of conceptual models that women use to describe distress. And one of the big ones is the term tension. So these two papers here are examples of research I've done looking at, on the one hand, kind of original research on the left side of your screen, looking at how women in North India are using this term, the English term tension, to describe generalized distress and, sort of causes and consequences of it. And then the more recent article that's at the bottom right of the screen is a systematic literature review of all the research that's been done on this topic. And I'm certainly not the only person who has noticed or who has done research about the ways in which this construct and this term, tension, reflects a kind of different kind of generalized distress than what we might think of as clinical depression or anxiety. And I've even gone so far to do some quantitative comparison where I've developed scales for measuring tension and then screened people for tension alongside depression and anxiety, and then done some factor analysis work to see if, like some people might suggest that tension is just a code term or a local term for depression or for anxiety, and that really does not seem to be the case. So I don't want to say here that women are lacking psychiatric literacy. That's not the claim I'm trying to make. Rather, I'm trying to make the claim here that the women I've worked with have very different nosological categories, right? Categories of what stress-related illness looks like and like what its symptoms are and how it should be treated that do not necessarily map on to traditional sort of psychiatric diagnostic categories. So again, there's this seeming lack of women internalizing or thinking about their own distress through the language and the sort of conceptual model of psychiatry in this setting. That doesn't mean that women are unaware of it, again, but that they don't take it on as their own, generally speaking. And I'll tell you more about that in a moment. The third part of our results was this question of whether or not women are aware of psychiatric resources in their communities. And this gets back to those two vignettes that I shared with you a little while ago. So when we read women those vignettes and asked what kind of help they would recommend for each protagonist, they gave us lots of suggestions. Some women gave us more than one suggestion, which is why the total count here, if you were to add up the counts in these categories, is greater than our sample size. But the most common recommendation women gave was for those two fictional protagonists to talk with a friend or a family member first. So go to a social contact first. The other two most common types of responses were that women should go to a medical clinic or a hospital. Sometimes women specifically named psychiatric providers when we asked them about this, or that they should seek counseling, which in this context could refer to clinical counseling, and often did. And so I'll also just quickly note that a very small number of people suggested going to a religious healer. This doesn't mean seeking advice from a religious leader, but it's rather going for like an exorcism ceremony. And it implies that women who gave this answer thought that the protagonist might be suffering from some sort of spirit possession or black magic that they needed to have spiritually removed. And I will say this used to be a pretty common model of understanding the seemingly irrational behavior that might come with a psychiatric diagnosis in India. But in this particular study sample, it was something people talked about very little and rarely took seriously. In fact, quite a few people in our study criticized this model as being sort of superstitious. Women mentioned social contacts, but they also mentioned that the women who were suffering from these fictional depression and anxiety symptoms might need to seek medical counseling. And they were often able to identify specific practitioners or hospitals that could provide that kind of psychiatric care. Okay, last set of results. I want to make sure we leave a little time for discussion today. Would women seek psychiatric care for themselves? So I'm going to show you a few of women's responses to this question, but the long and short answer is pretty much no. So this protagonist or this respondent says, in my family, we faced many problems, like issues with my mother and father-in-law, financial issues, we were considering a divorce, but our family gave us some counseling at home, which is why we didn't undergo any psychiatrist counseling. And so you can see in this respondent's statement kind of this notion reflected that keeping problems within the family is the sort of preferred course of action. And a second woman said something similar. So she said, I'll try to find a solution at home itself. Whoever's at home is the person she'll talk to when we asked, who would you go to? She says, presently, my husband is the person. If not solved at home, I'll go to my mother. Next, I'll go to friends. And finally, if not solved there, I will go to the doctor. And so again, there's this notion that the first resort should be to keep problems within the family and only seek clinical care as kind of a last resort. Some women, quite a few women, also expressed feeling like psychiatric care was not for them, even though they themselves often described pretty intensive symptoms of distress. So this is one example of a conversation between the interviewer and the respondent, where the interviewer asks, could you tell me why you didn't ever feel you should consult a psychologist? And the participant says, I didn't feel like it. And then they probe and they say, well, why? Is there a reason? And the participant says, no, madam, I didn't think like that, like I should go to them and consult. And then the interviewer probes again and says, did you not have information about this? So you didn't know about where to go? And the participant responds, I was aware of it, but I didn't go. So here she's saying, it's not that I lacked information, I just didn't feel like it was for me. And I'll just share one last quote in this category with you. Some women also expressed fears about what would happen if they went to a psychiatrist or a psychologist. So one woman talked about how people would call her mad. If I went to that doctor, she says, they would call me mental or crazy. And another woman talked about factors limiting her mobility and the fact that it would be very difficult for her to be able to go out and seek this kind of care for herself. So there was this kind of combination of notions of women, on the one hand, feeling like psychiatry might not be for them, wanting to keep sort of these largely socially derived sources of stress within social circles rather than sharing them outward. And then also some real concerns around stigma that does attach to psychiatric providers. So to wrap up our findings of this study, women did experience pretty high levels of distress in general in this study with largely social and relational causes. They did differentiate and they had a sort of conception of understanding that mental disorders and physical disorders are different from one another, but did not necessarily apply sort of clinical psychiatric terminology to identify and describe those different kinds of disorders. They often recommended counseling or clinical care of some sort for people in fictional vignettes who were experiencing depression and anxiety symptoms, sometimes very specifically pointing to like they should go see this doctor. But uniformly across the entire study sample, they rejected psychiatric care for themselves. And I should say that one of the study provisions was anyone who screened positive for any level of depression symptoms had access to free clinical care with fees covered, transportation covered, and a gender and age matched escort to go with them to an appointment. And no one availed themselves of that. So taking all these findings together, this paper concludes that, this paradigm of task shifting towards the end of increasing psychiatric care availability to close the mental health gap in very populous countries like India, where there isn't a lot of psychiatric care availability, particularly if it's done without any kind of cultural adaptation, as that meta-analysis suggested could be done. It's unlikely to reach people like those in this study because they fundamentally do not view sort of psychiatric conditions and care as relevant for the kinds of distress they experience, which are mostly social in nature, and though sometimes severe, are not seen as psychiatric disorder. And my suspicion is that that fact is at least partially responsible for the very modest effects that we do see in task sharing interventions in South Asia and in many other parts of the world, and problems with uptake, right? And with long-term sort of effectiveness that is relatively limited in these studies is simply the fact that there's kind of a cultural mismatch going on here. And again, this doesn't mean that task sharing or task shifting type interventions are wrong or that they don't have a place in the world of global mental health at all, but it does sort of suggest that we might want to try some other models or consider incorporating some slightly different approaches within task sharing models, or maybe, moving those task sharing paradigms out of clinical settings if people really aren't seemingly interested in going to clinics for distress. So very quickly, again, I want to leave a little bit of time at the end of the talk. I want to just close by considering some alternatives, right? What could a modified task sharing approach look like in global mental health? I think one of the key important things to do here would be to use culturally derived language and instruments alongside standard sort of both screening and treatment models that exist in those manualized formats. Many studies do some degree of cultural adaptation, but this is something that's often viewed in global mental health as a laborious process, as one that might be unnecessary, and as one that, is sort of like a nice luxury that we don't have time or energy to do. But I and many folks who are my peers have done a lot of work in developing culturally specific sort of language and even measurement tools. So I've developed a tool for measuring tension in India that is not a replacement for a depression and anxiety screener, but could be used alongside it to make some sort of more relevant screening processes happen. And that's something that many of my colleagues have successfully done in other parts of the world as well. There's also an existing database that I want to make a plug for called the Global Mental Health Assessment Database that collects the research that folks like I and others have done to develop these either locally derived scales or locally validated translations of sort of psychiatric assessment tools for many, many countries all over the world. And so when people say, oh, I'd like to do this cultural adaptation, but I'm not a qualitative social scientist, or I'm not a cultural expert, or I don't have time, I often point them in this direction because a lot of that work has been done. And that's not something that folks in global mental health and in sort of transcultural psychiatry are necessarily aware of, but folks on my side of the world in social sciences, medical anthropology have done a lot of this kind of work, and it's flawed work. It's not perfect work, but at least there are resources that exist out there in the published literature that can save a lot of time for those folks who are interested in developing more sort of culturally specific or culturally adapted mental health work. A second alternative is a more collaborative model to task shifting or task sharing intervention design, one that might build on existing resources within communities rather than introducing these new and sort of complex structures of care provision. We do know, based on many, many years of cultural study and just being human, that distress is a fundamental part of the human experience, and that every culture around the world has existing structures and tools for managing distress, right? That may look very, very different than sort of psychiatric or clinical care. And so one thing I often encourage folks to do who are in this space is to take just a little bit of time to find out what people are already doing to manage distress and see if there's a way to sort of incorporate some of those existing and clearly culturally acceptable practices. And I say clearly because if they're happening on a widespread basis, right? That guarantees that they're culturally acceptable to an extent, at least. To do that instead of, sort of introducing an entirely new paradigm and having to engineer a complicated and often quite short-lived intervention that resolves around getting people to engage in new kinds of clinical care. So this slide shows just a few examples of sort of distress management techniques that women in our study talked about using, right? So women talked about going to temples. They talked about using therapies from Ayurveda or homeopathy to systems that are pretty common in India. They talked about support groups that are specific for women or people with distress. They talked about going to women-specific community resources that already exist, like this is a women-only police station, which are pretty common in India. So figuring out how to incorporate some of those existing culturally acceptable practices would be, I think, a great improvement in this space. And finally, I'd love to see more intervention designs that actually test non-psychiatric alternatives against psychiatric interventions. So if you think back to the study by Patel and colleagues that I described for you at the beginning of the talk, that randomized controlled trial was set up to test regular psychiatric care against this task sharing sort of community-based, but still clinical intervention. It would have been amazing to see how either of those would have performed against other sort of resource provision or stress alleviating approaches that aren't clinical, right? And because it didn't include those things, we can't say whether task sharing was more effective than, say, an economic intervention to address some of the sources of insecurity that women talked about as being distressing to them, or an educational or some kind of social intervention. I also haven't seen many studies, although there's some happening, including one with this group, that look at non-biomedical stress alleviation practices and test those against sort of typical psychiatry-based interventions. So I would love to see more robust studies that are looking at how these kinds of non-clinical interventions that have the real potential to reduce stress could perform alongside of our existing understanding of the sort of current best practice, which is task sharing and psychiatric care. Okay, I know I've thrown a lot of information at you there, and I am going to go ahead and wrap it up. I want to thank you all so much for your attention and leave a few moments for questions, or encourage you to reach out to me via email if you have questions moving forward from here. Thank you all so much.
Thank you. Thank you so much, Dr. Weaver. That was super insightful. Does anybody have any questions?
Yeah, this is Carl Krupp. Hi, Joe.
Hi, Carl.
I love your work. We've been working together for a long time. One of the things that I mean, to be honest with you, you brought up this idea of trying to measure things, and it's interesting because we always force our measurements reflect obviously the medical system that we grew up in and that we represent. And I often wonder when we're in India what we're actually measuring with some of these tools. I really don't know. I mean, I'm really curious if one of the things I'm really interested in, and I've never gotten a chance to go back more to it, and I'm hoping we get a chance to collaborate on some of these things. Mysore is kind of, up until recently, I think it was the suicide capital of India. More suicides than anywhere else, and many, I would say the vast majority of them are among women in India, rather than men, which is kind of interesting too. There's a whole gendered aspect to that. But I'm really curious if you think we could predict suicide ideation in Indian women, because it's such a big problem, using the tools that we have, or whether we should try to develop better tools that are culturally more appropriate for doing that.
It's a great question. And one that's been top of mind for me for a long time too, because when you talk with people about what distresses them, you are going to run into instances where people admit to having had suicidal ideation or even made suicide attempts. And that happens pretty often in this research. Of course, as you know, we have good provisions in place for when that happens. But one thing I guess I have a couple of reflections. One is that suicidal ideation and discussion of it seem to me, and this is not just coming from me, but also coming from the work of other folks who I respect very highly, like Jocelyn Chua, those kinds of admissions have very different sort of cultural meaning and also consequences in India as opposed to in the United States, where, you know, in the US, if someone admits to suicidal ideation, depending on who they're admitting it to, that could trigger police intervention, it could trigger psychiatric intervention, it could trigger all kinds of sort of like legal constraints on freedom and kind of actions to limit liability and also to hopefully, you know, keep that person safe. Whereas those kinds of structures don't exist so much in India, and the ways in which people sort of talk about and think about the role of suicide culturally, I think is really different. And so all of that is to say, I do think that we need more culturally sensitive ways of predicting and assessing what it means to, or what other sort of risk factors for suicide beyond saying I have felt suicidal, right? Because that means something very different in these different cultural contexts. And I think our existing ways of screening for that are pretty coarse and largely not culturally adapted at all. What that would look like, I'm not entirely sure because I haven't focused very much. You know, it's been a part of the work that I do, but I haven't focused on asking people about experiences of suicidal ideation or about, you know, sort of symptoms leading up to that. But my instinct is to say that, yes, I think we really do need a better way to predict that because of the very different sort of meanings and signals verbally and behaviorally that people give around that kind of high level of distress across cultures.
Yeah, I mean, one of the things I always wondered is how that correlates with some of your concepts of tension. Mm-hmm. You know, it would be really interesting to see if there's a, you know, if there's actually a correlation there and how it correlates exactly. Because my impression is that women, well, the other thing that I worry a lot when, again, and you've seen, we do a lot of work in India with these, with the, you know, the lower income women, there is such a desire to please sometimes in these groups. When you do focus groups and when you do interviews, that social desirability bias it's like veterans, you know, I mean, I've never wanted to work in veterans because they desire and they need help so much that they're willing to agree with practically anything you say. And I often wonder how that tendency shapes what we see and what we hear and whether it just confirms what we already think. Mm-hmm. Rather than giving us insights into what is actually happening. And then I'll leave you alone after that. I've just, you know, we've every time we talk for a long time. So I'll cut it off there.
Oh, thank you. Those are, I mean, I feel like you kind of touched on two things there. One is tension and how it might relate to really acute distress that could lead to suicide. And the second one was this question of sort of bias and response bias in research processes. So I'll try to address those both. And I think the first one is something I've written about. So tension is a term that gets used, as you know, and as anyone who spent any time in India knows, all the time. It's not just specific to India, it's used across the subcontinent. And it's the actual English term that people integrate into Hindi or Kannada conversation. And this concept and term itself has kind of taken on a special cultural meaning in this setting. It's sort of used in the same way that stress or being stressed is used, I think, in the United States to index, you know, like someone could tell you they're stressed in the US and it might mean they've just had a bad day. Or if they are like really stressed, that could mean that they are in need of help and they're in a severe situation. And part of, I think, why that term is so common and likewise why the term tension is so common in India is because it's a shape-shifting term. It can mean so many different things. It's non-stigmatizing, right? In the way that, say, for example, suicidal ideation is really stigmatized in the United States and people would be hesitant to mention that in public discussion. that's not the case for a term like stress or tension. So a person could rely on that term to allow them to express some of their distress in a non-stigmatizing way. And I see that in tension in India too. I've had women I've worked with who are exceedingly depressed, who are actively considering suicide, who use the term tension to describe that state. And I've had women who are pretty happy and use that term to describe, minor life annoyances on an everyday basis. And so in some ways it's the very broadness of the term is what makes it interesting to me and I think useful for people, but also really hard to pin down, right? And so I think people do have definitely based on the research I've done, people do have this idea that tension, when it is not addressed, if it's allowed to build up too much, can be dangerous, right? Can lead to madness or suicide. And so I think there's something there, but I'm not sure if that is the sort of way forward for thinking about culturally sensitive and really more effective ways of screening people for potential self-harm or suicide. And then very quickly, the response bias question is a huge one. And I think, one of the things I love about this work is working with the folks at PHRI who are themselves local, who are more similar to the people that they work with in these studies than I am. I think that's one way to kind of reduce response bias, but cross-culturally, that's always a challenge. And it's something that never entirely goes away. But I think you're right that I didn't feel that so much in our urban setting, in the urban work we've done, but particularly in the more rural settings where, the folks who are at PHRI are, even though they're local, they are native to India and speak Kannada fluently, are still perceived as outsiders. I think there's less of that in the urban setting because they themselves are urban dwellers who are part of the community, but it's always a challenge, right? Yeah, anyway, I know we're probably at time, so I'll leave it there, but thank you all again for being here. I really appreciate it and for the good questions, Carl.
Thank you, Dr. Weir. I actually have a quick question to ask.
Yeah,
I just wanted some insight into why were study participants female only? And also, it was interesting to see how for fictional characters, they would recommend, them to seek care. However, for themselves, they wouldn't. So I want to know if you have any insight, if there's stigma attached to them, for their own children, would they seek help, mental health care or would they not? I don't know if you have any insight on that.
Yeah. So why women? I started working primarily with women in India long ago for mostly pragmatic reasons, because as a woman working in India, which is a pretty strongly patriarchal society, it was going to be very hard for me, even though I speak pretty good Hindi, to speak with men and have it be sort of a comfortable interaction or one that was considered culturally acceptable, especially as a foreign woman. So that was part of what led me towards working primarily with women in the first place. But also, I think it is very much the case that women in this part of India and in India more generally are still dealing with a lot of kind of restrictions on everyday freedoms and mobility that men are less subject to. And so if a man wanted to, say, seek psychiatric care and didn't want his family to know about it, he would most likely be able to make that happen. But one thing I hear over and over from women is, even if I wanted to seek psychiatric care, I wouldn't, or I couldn't because my family would find out. And, I would have to ask people for money. So a lot of women that we work with don't have total financial autonomy, don't have money that's available to them without asking a family member. Or they might observe PERDA or other restrictions on sort of mobility that would mean they would need an escort to go with them. So it would be impossible to keep it secret if they were going out. Or if they went out and didn't tell people where they were going, their neighbors might gossip, like the one woman who I quoted earlier, right? So there's these kinds of social surveillance and personal freedom and liberty things that are at play for women in part that I think are really interesting and that are certainly not untrue for men in this setting, but less true for men. And I find that interesting. So that's another reason why I'm particularly interested in working with women. Yes, there's stigma, to answer your second question, for sure. But I do think that's some of it. And in the sort of medical and global mental health literature, when there is discussion of cultural mismatch or resistance to psychiatric care, it's almost always immediately boiled down to a question of stigma and need for psychoeducation, right? So there are studies out there. I didn't mean to oversimplify in my talk today. There are studies out there in the global mental health and in the task sharing world that do talk about culturally specific barriers and how to deal with them. But it almost always comes down to there's stigma. We need to get rid of the stigma. We need to educate people into this sort of acceptable sense that biomedical disorders of mental health are not, personal failings. And that is part of it, right? There were certainly women like the one I quoted in the presentation today who said, yeah, absolutely. People would call me crazy. People would think I was insane, or that they would tease me and say I was mad if they found out I was seeing somebody for these kinds of issues. But I don't think it's just that. And I think I'm dissatisfied with most of the discussions I see in the literature that just boil sort of cultural concerns down to stigma, because I think there's something deeper going on here too, involving how much people identify with these conceptions of sort of mental health and illness they're kind of the water we swim in the United States to a large extent, for folks who are raised in the US. Biomedical psychiatry, the idea that depression is a disease that's real, has been enculturated into us since we were kids. It's part of really our cultural fabric for understanding distress and wellness and sort of human existence. And I find that not to be the case for women in India. So I talked already about how women don't sort of internalize or self-identify with disease states when they're experiencing distress. And I think that is another very large part of what's going on here. So it's not just stigma that's keeping women from wanting to seek care for themselves, although that is part of it. And I don't want to minimize that, but I think it's also just this really non-biomedical way of understanding distress and illness and what people should do when they're distressed. And it's that concerns me the most when we think about this big, sort of laying the blanket of task sharing around the world and hoping that that's going to help. I think task sharing can do a lot around stigma because psychoeducation can be built into task sharing interventions. But, what kinds of changes in worldviews are we expecting of people or requiring of people when we introduce new models of clinical care and ask them to manage their distress in those ways? That's a much heavier lift. And it's one that, based on the results of existing task sharing interventions, is one that I'm not 100% confident is warranted in all cases. And again, that there's plenty of places where I think it is very much warranted, but, taking the place where I work as a case study, I think there are other ways that might be more effective for helping the women I work with to manage distress besides encouraging them to seek clinical care, which really seems to kind of not mesh with their view of themselves and, what they want. Yeah.
Excellent. Thank you.
Thanks,
On behalf
Joe.
of the Global Health.
Yep.
Go ahead, Dr. Krupp. On behalf of the Global Health Institute, NESCOP Global Health Programs, and the Global Health Alliance, thank you, Dr. Hooper, for your insightful presentation and for your commitment to global mental health. And to our audience, thank you for joining us. You can access today's lecture and previous events at our Global Health Speaker Series webpage. And we look forward to seeing everyone in the fall. Thank you.
Wonderful. Thank you all so much.